Hello guys, welcome back to Clinically Clear. Today we'll be covering another very important topic, that is viral keratitis. So viral keratitis is very common these days due to the overuse of topical antibiotics. And always it is cornea along with conjunctiva. So it can be also called as keratoconjunctivitis. The most common is herpes simplex virus. Herpes simplex virus is the most common. Two viruses come under herpes simplex virus, HSV1 and HSV2. HSV2 causes neonatal ocular herpes. HSV1 causes primary ocular herpes and recurrent ocular herpes. Now they can interchange, but this is what happens most of the times. And HSV1, the mode of transmission is infected secretions come in contact with the mucous membrane of the eye. So because of close contact like kissing, etc. Whereas HSV2 in neonates, how does it spread? From the infected genital tract of the mother to the eye of the baby during birth. During birth. This is HSV2. And as we know, HSV1 causes skin lesions above the waist, like oral herpes and all that. HSV2 causes genital herpes, skin lesions below the waist. This is the etiology. Then coming to primary ocular herpes. Now, the first HSV infection in non-immune individuals, the first exposure to herpes simplex virus. Basically, non-immune. So, from birth to about 6 months, you cannot have primary ocular herpes because mother's passive immunity has been passed to the child. So up to 6 months, primary ocular herpes cannot be possible. Then 6 months to 5 years, it is commonly seen, and teens, it is commonly seen. Why? Think of it, close contact like kissing. 6 months to 5-year-old babies and young children, the parents, relatives will come, they'll be like, oh, you're so cute, they'll kiss the baby. So that can lead to spreading. And teens though, of course. And then features like, what are the features of primary ocular herpes? Features, you have fever, malaise, lymphadenopathy as systemic features, and in ocular features, it's more of conjunctivitis. So it is acute viral follicular conjunctivitis, that is the main presentation in primary ocular herpes. Apart from that, you can have vesicular blepharitis, that is herpes vesicles on the eyelids. You can have epithelial keratitis in the form of epithelial punctate keratitis. Then on the skin, you'll have what? Vesicles. Vesicles on the eyelid, as I told, vesicular blepharitis. Also on the face, on the lips. These are the features, systemic features, ocular features, and skin features. Treatment, primary ocular herpes is generally self-limiting. But the problem is, the herpes will go and establish a latent infection in the trigeminal ganglion. We don't want that. Why? Because then it will lead to recurrent ocular herpes. So what we'll give? We'll immediately give oral acyclovir. No use of giving topical acyclovir because it cannot kill the herpes latent infection in the trigeminal ganglion. So we give oral acyclovir. Along with that, for the primary ocular herpes, we give atropine, cycloplegic. We give other supportive therapy like dark goggles and anti-inflammatory analgesics, etc. This is about primary ocular herpes. Now, recurrent ocular herpes, what happens? There are certain trigger factors like physical exhaustion, menstrual stress, emotional stress, exposure to sunlight, trauma, fever, infections. All these, what it leads to is reactivation of the herpes simplex virus where it is supposed to be latent. So now what happens? From latent infection, they start actively replicating, active replication, and active replication makes them descend along the nerves from the ganglion, leading to once again lesions. This is known as recurrent ocular herpes. Now this can be in multiple forms. Let's go layer by layer. If it involves more of the corneal epithelium, then it is known as epithelial keratitis. Now symptoms are majoritarily same for all of them. That is photophobia, pain, discomfort, irritation, blurring of vision, watering, redness, all those typical inflammatory findings and findings of keratitis. Now, mainly you can have ocular signs. You can have follicular conjunctivitis and recurrent ocular herpes, that is viral follicular conjunctivitis, and again vesicles on the eyelid, so vesicular blepharitis. But mainly let's focus on the corneal signs. So it starts as epithelial punctate keratitis. So tiny superficial coarse punctate lesions on the corneal epithelium. They grow longitudinally and they become something known as dendritic ulcer. As you can see in this picture, dendritic ulcer is irregular zigzag shaped lesions with knobbed ends. Very important. Here you can see the ends are knobbed. In herpes simplex virus, the dendrites have knob dents. Dendritic ulcer is the most common clinical presentation. They have knob dents and they stain fluorescein. As you can see in this picture, they take up that fluorescein stain. If the dendritic ulcer enlarges and coalesces, then it will become what? It will become a large geographic ulcer, map-like. It looks like a geography map, right? So that is why it's known as geographic ulcer. So superficial epithelial punctate keratitis to the most common clinical presentation, that is dendritic ulcer with knob dents, and then to geographic ulcer. This is about the what corneal signs of epithelial keratitis. Then treatment, we go for definitive treatment. Definitive treatment is what? Antivirals. So antivirals are the drug of choice. You will give topical acyclovir 3% eye ointment, or you can use ganciclovir 0.15%. But acyclovir has the maximum therapeutic efficacy, and it has very low toxicity. So we prefer acyclovir over ganciclovir, which is more toxic. If the epithelial keratitis is very severe, then we give oral acyclovir. And what do? We also give, if let's say it is resistant to antiviral therapy, then we go for mechanical debridement. When we do mechanical debridement, along with the virus laden cells, we also remove a healthy rim of cells. This will promote healing. So remove a healthy rim of cells and the virus laden cells. This is about definitive therapy. Supportive therapy, just like any other case of keratitis, you will give atropine, you will give anti-inflammatory analgesics, dark goggles. You should not give steroids. Why? Steroids cause corneal epithelium thinning. So already the epithelium has ulcers, lesions. So if you give steroids, it will cause further thinning of the corneal epithelium. So this is about epithelial keratitis. So now we are done with the corneal epithelium. Next we'll go to the stroma of the cornea. So stromal keratitis can be of two types. That is immune stromal keratitis or interstitial stromal keratitis or non-necrotizing stromal keratitis and necrotizing stromal keratitis. Now immune keratitis, it's there in the name, immune. So something to do with our immunity. So it is a type 3 hypersensitivity reaction to the viral antigen in the corneal stroma. So patient will have, so it is basically our own immune reaction. Okay. So type 3 hypersensitivity reaction. Patient will have blurring of vision. Again, the generic symptom, blurring of vision, discomfort, photophobia, irritation, all that. Sign here is because of the hypersensitivity reaction, there is inflammatory infiltration of the corneal stroma, but the epithelium is intact. Very, very important. See, in epithelial keratitis, epithelium was screwed, but stroma was fine. Here, stroma is screwed, but epithelium is fine. So, stromal inflammatory infiltrate you can see, but epithelium is intact. So because epithelium is intact, you can give steroids. Why? Because there is no risk of severe epithelial thinning, no? So we can give topical steroids. So we give topical steroids so that the inflammation is suppressed. Apart from that, we'll give standard topical antiviral and we'll give supportive therapy like atropine, the dark goggles, anti-inflammatory analgesics, etc. So that is why we give topical steroids, important. Then what happens? There's another variety of stromal keratitis known as necrotizing stromal keratitis. Here there is active viral invasion into the stroma. So when there is active viral invasion into the stroma, it will lead to necrosis of the tissues. So here same symptoms, that is the irritation, photophobia, blurring, etc. But because of so much necrosis and invasion, there will be more of redness and pain along with all this. So redness and pain. Signs are a bit different. Here, because of the necrosis, you will see cheesy white necrotic tissue in the corneal stroma. Cheesy white necrotic infiltrate in the corneal stroma. Treatment, again same, topical steroids, but this is a more severe form of stromal keratitis. So you will give systemic antivirals. You won't give topical acyclovir, but you will give oral acyclovir, systemic antivirals. And again, topical steroids and supportive therapy. That is about stromal keratitis. So now once we're done with stroma, we go to the corneal endothelium, HSV endothelitis. HSV endothelitis is a type 4 hypersensitivity reaction to the viral antigen in the corneal endothelium. So any type 4 hypersensitivity reaction, eventually it will lead to chronic damage to the tissue, right? So symptoms again same bro, blurring of vision, ocular discomfort, photophobia, irritation, then stuff like that, watering. But important thing here is colored halos. Why colored halos? Because of corneal edema, stromal edema. Why? We know that the corneal endothelium prevents the aqueous humor from entering the corneal stroma. But in HSV endothelitis, the corneal endothelium is damaged. So now there is stromal edema, accumulation of water in the stroma. And the stromal edema in HSV endothelitis is in the form of a disc-shaped patch. Epithelium is still intact. It is underneath an intact corneal epithelium. The edema is in the stroma. It is in the form of disc-shaped patch. Hence, it is known as disciform keratitis. So, HSV endothelitis leads to disciform keratitis. Apart from that, you will have two other signs: corneal anesthesia and vesically sterile immune ring, basically formation of ring due to immune complex deposition, type 4 hypersensitivity reaction. No, so some immune complexes might be there, and corneal anesthesia will be there. That these two also, if you don't remember, it's fine. But disciform keratitis is very, very important in HSV endothelitis. Then next type is metaherpetic keratitis. Metaherpetic keratitis or neurotrophic ulceration under recurrent ocular herpes. Here, the ulcer is sterile. Neurotrophic ulcer. Ulcer is sterile. It is not due to active viral infection. There is no active HSV infection. What happens post herpes? Post herpes simplex viral keratitis. Two things: if there are complications like fifth cranial nerve palsy, or if there is any defective basement membrane, then what happens? There is abnormal healing. Abnormal healing leads to some epithelial defects, persistent epithelial defects which do not heal. These persistent epithelial defects form this sterile epithelial ulcer, metaherpetic keratitis or neurotrophic ulcer. Symptoms same as always: photophobia, blurring, irritation, etc. Signs, what you will do here, the sign is it is an epithelial ulcer with thick gray margins. So you just have an epithelial ulcer, a sterile epithelial ulcer. Very, very important. Metaherpetic keratitis, the epithelial ulcer is sterile epithelial ulcer with thick gray margins. So the corneal ulcer has no infection. It is just that it is not healing. So how will you treat it? You will promote healing. Abnormal healing is the reason. So you'll treat it with promoting healing. How will you promote healing? By soft bandage, contact lens, by giving lubricant, by giving vitamin C, etc. Apart from that, metaherpetic keratitis, then you also have herpetic uveitis and herpetic trabeculitis. Herpetic trabeculitis can lead to glaucoma. So that is it for recurrent ocular herpes, epithelial keratitis, stromal keratitis, under which you have non-necrotizing or immune and necrotizing, then HSV endothelitis, metaherpetic keratitis, herpetic trabeculitis, and herpetic uveitis. That is it for herpes simplex virus keratitis. If you felt like I went a bit too fast, I should stop and I should slow down a bit. Please let me know in the comments, because even I don't know how fast I'm going. This is new to me as well. So please do let me know. Thank you for watching.